All right. So I am somewhat of a walker, so you might see me go back and forth, and it sounds like I'm a little loud. So I'm going to hop down and be among you. The other thing I'd like to do today is tell you a little bit about the context of this lecture. Some of the big problems people have with substance use disorders is they have a hard time understanding why it is so difficult to get people to move from the state of having an addiction into remission, and why they don't respond well sometimes to well-intentioned interventions to help. And the frame we're going to do on this lecture today is to talk a little bit about the hardwiring that occurs in the brain that makes it such a difficult disease to get into remission. I will say that once someone gets into remission from addiction once, they have a good prognosis of either remaining there or, if they have intermittent relapses, re-engaging in recovery down the road, as long as they have appropriate support around them to do so. So in that way, it's a lot like any other chronic condition, such as diabetes or hypertension. When you deal with those issues, no, I don't think anyone in this crowd has ever had anyone that's been completely adherent to your recommendations in your care. And so it's not surprising that, by the way, this also happens with this illness. Okay, so what I'm going to do, here's my disclosures. I don't think I have anything which causes problems with this talk. I do have a stock in a healthcare company, but I'm not going to talk to you about anything in that regard. So what we're going to do is we're going to talk about how addiction reprograms the brain, and our understanding of this is limited but is growing rapidly every year. If we do take the information we have, collect it together, we can use it to really maximize the prognosis of recovery. Its treatment, what happens with addiction is it reprograms the brain to think and act in a different way. And what treatment in recovery should be is a reprogramming of that reprogramming. That you literally have to have a series of things occur in that person's world which will change how they think about things, how they conceptualize things, so that they can remain in remission. This lecture will also tell you that its effects on the brain are pervasive in multiple circuits, so you have to rewire lots of different things. And how that's going to happen is described here. What I'm going to do is I'm going to talk about one of the many ways that addiction reprograms the brain. And we're going to describe that, and then I'm going to have a summary slide that says, so what do you need to do in effective treatment to make it different? So here's how it goes wrong, here's how it gets haywire, here's how it gets reprogrammed, and then what has to happen in order to instill and maintain remission. So I'm going to start off talking about the most well-known change in the brain, and that occurs in what's called the mesolimbic. The old-fashioned term is the mesolimbic reward circuitry. It's actually has a better name today, but that's what a lot of people call it. And what I'm going to do is talk about how drugs affect this circuitry. I'll show you where it is in a minute, but certain drugs, we've known this for many years. This is slides from 1988, that certain drugs have very profound effects on the level of dopamine in a very small but highly important part of deep neural circuits in the brain. I'll show you where that is in a minute. And in rats, if you take micromolar bits of morphine and you drip it on this area, dopamine levels rise very high. We'll tell you what that causes in a minute. So just take that in. Morphine does that. Cocaine does that. Nicotine does that. Ethanol does that. They all have the same effect on this mesolimbic circuitry, motivational or reward circuitry. But importantly, certain behaviors do that too. The promise of food, especially highly caloric food, causes a rise of dopamine in this area of the brain. The possibility of a sexual encounter, and this in rats, causes a rise in this area. So it turns out that this circuitry is important for life-sustaining activities. And what drugs that are misused do is they're false stimulators of that circuit. So if you were to say to someone who is in the middle of an alcohol use disorder, just stop doing that, it would be like saying to yourself, well, you know, eating is overrated. I think I just won't eat. And you'd have the same response. You'd say, okay, I'm not going to eat. I'm going to go on a diet. Time goes on, blood sugar drops. You begin to say, oh, I'm really hungry. So if you don't have an addiction disorder, think about something like that. Okay, so we knew this has been known for a long time, since the late 1980s, early 1990s, the mesolimbic reward circuitry. So that led to more information. These dopamine neurons are in the ventral tegmental area. I'll show that to you now. So the ventral tegmental area is, which slide is around more people? The ventral tegmental area, you see it outlined here, is here, and it projects forward in a bundle into something called the nucleus accumbens, very deep in the brain. And as we all know about brain circuitry, the oldest circuitry is preserved because it is the most vital. And so it is the most vital circuitry which is changed by drugs of misuse. So dopamine neurons in the ventral tegmental area project anteriorly and inferiorly to the nucleus accumbens. This primitive brain structure drives life-sustaining activities, foraging for food and water, escaping from harm, reinforcing sexual behavior, even child rearing. These are all critical life-sustaining behaviors that drugs of misuse activate in a different way in people that are susceptible to addictions. And interestingly enough, all drugs of misuse seem to activate the circuit, but do it in a different way, and I'll show you more about that in a minute. So you can and you're going to learn that not only does this stimulate substance use, it stimulates all of the downwind effects, such as learning how to be efficient at it, figuring out how to reprioritize it. You're getting an idea about what it's like to live in the brain of someone who has a substance use disorder. So there's a diagram of the dopamine reward circuit, and I'll show it to you over here. Here's the ventral tegmental area and nucleus accumbens here. And, okay. So that was all from the 1990s and that sort of thing. Well, it turns out that it's, no surprise, it's the brain. More complicated than that. It's more complex than just a stimulation of this dopamine circuit. This is actually the work of Eric Nestler et al., and this is from the Surgeon General's report on addiction, facing addiction in America. And this is actually taken from a paper, a synthetic paper that looked at lots of the literature by Eric Nestler. And it shows that not only do we know, looking at the ventral tegmental area and the nucleus accumbens here, and the neurons in there, not only do we know how that these drugs stimulate this area, we now know how they stimulate this area, and they stimulate the neurons in this area in very different fashions. So for instance, stimulants over here block reuptake of dopamine, such as cocaine, of dopamine at this synapse. And things like alcohol stimulate multiple areas of the brain, presynaptically here, and at the neuronal surface there, opioids in multiple areas as well. So we not only know that this area is highly stimulated, we also know how. So here's one of these synthetic slides. Now that you know this data, you can actually extrapolate what is important and meaningful in treating people with substance use disorders. Well, the first is, in those who have developed addiction, moderating use is ineffective. Why? For the same reason that it's hard to diet. For the same reason that if you're a teenager, it's hard not to think about sex. Right? So moderating and saying, why don't you cut down, is not an effective intervention if you've crossed some weird chasm between misuse of the substance and addiction. And in fact, one of the ways you can diagnose someone, let's say you have someone that has hypertension, shows up in your practice, and you say, you really need to cut down on your alcohol. It's causing problems there. Or they're having elevated liver function tests. Please cut down. And you, over and over again, you say, please cut down. And over and over again, they fail to do that. And they seem intended at the time. They're almost screaming to you, I'm not a misuser of alcohol. I have an alcohol use disorder. Does that make sense? Okay. The other thing is, if you have someone that has a substance use disorder, substituting other rewards pales when compared to the deep activation of these circuits. So saying, well, get the reward from going out and running every morning. That might work, but is it going to decrease the drinking? Probably not. It also means that the initial and primary goal of substance use disorder treatment is stopping substance misuse. That's the goal. Again, if you have someone that doesn't have a substance use disorder, this happened, as a matter of fact, I used to use this diagnostically in my practice. I've had people actually, I know this is nuts, show up and say, I think I might have an alcohol problem. Can you help me figure that out? And first of all, if someone shows up in your office asking that question, what do you think the answer is? No. Because if they have an alcohol problem, they're not going to tell you, right? Or if they do, they're going to minimize it. Or if you say, I'm going to cut that down. I mean, that is over-exaggeration. There might be some people that do that because it's happened with me. And I've actually had people that I want to find out. And I said, well, let's just have you moderate your use over a period of time. Were you successful? Yes, I was successful. Okay, I'll see you in a month. Bring your wife the next time. Bring your husband. Bring your children. Well, did he stop drinking? Yes. Did he decrease his drinking? Yes. Well, you probably don't have a substance use disorder. Okay. So the other thing about this mesolimbic activation stuff is that corollary behaviors such as food misuse, sexually compulsive behaviors, gambling, and misuse of nicotine or caffeine often occur more frequently in this group. If you want to know who's alcoholic, if you want to see a big tranche of folks with alcohol use disorder, you'll go to Gamblers Anonymous. The data shows that 65 to 80%, depending on the group, of those people in Gamblers Anonymous are also alcoholics. So they tend to co-migrate together through the population. Okay, does everyone understand the format of the lecture now? We're going to talk about the problem in the brain, how it changes. We're going to talk about what that means for treatment. Okay, so we're going to move on then. We're going to start talking about a more different aspect of this. This is a fascinating concept. This activation of the mesolimbic dopamine center is more complex than a switch, on or off. Activate it by taking drinking, deactivate it. And this is the work of Kent Berridge et al. At the University of Michigan. The concept here, and probably the leading model for how this circuitry is changed, is something that he calls incentive salience. So I'm going to describe the research he did, and then I'm going to hopefully have you understand some subtleties that make it different than an on-off switch. So the seminal study he did was went in, destroyed this area of the brain, the ventral tegmental area of the brain, in rats, and noted that they continued to enjoy food but wouldn't work for it. See, do I have that? No, I don't have that slide. Okay, and how do they know that? Well, surprisingly, you just watch the facial features of a rat when they eat. And food they like, they do a different kind of twist of their mouth than if they are just eating for sustenance. And by the way, we also do that as humans. One of the frontal releasing signs we learned in medical school is actually a type of movement that a baby makes, a snout movement that a child makes, which is related to food satisfaction. So, if you destroy this ventral tegmental area, they enjoy the food, but they don't go get it. They'll just lay in the side of the cage and starve to death. But if you feed them, they'll say, wow, this is great. Hopefully they won't say that, then you have something else on your hands, right? Okay. So this was a seminal study, and he repeated it in multiple different ways to prove that what this circuitry does not subtend pleasure. It subtends three processes that you see here. The first is learning. That if there is a substance which goes in the brain, you literally become more and more efficient over time and reach an asymptotic rise of learning how to perfect the acquisition of that. Now you can understand that was good for us, Homo sapiens, when we were hunters and gatherers, right? If you came across a patch of berries in the forest and you're having these succulent berries and the next year rolls around, you will remember how to get to that spot because it was life-sustaining behaviors. The same thing is happening in people that have substance use disorders. It's that you learn over time to get better and better at the acquisition of the substances. And interestingly enough, over time, how much you like it goes down. So the learning becomes better, the liking becomes less, but the wanting keeps rising. And I've been around for a long time doing this work, so I can date myself back to the cocaine eras. When my patients would come in with cocaine addiction, I'd say, well, so are you pretty good at finding it? I can find it anywhere, doc. So tell me the last time that you really had a pleasurable experience with cocaine. And they would go, oh. No, I really like it, doc. Well, okay, tell me when it was really wonderful. 10 years ago? But yet, they have this immense hunger for the drug. That drug taught us more about this paradox of incentive salience than any other. So what you have with addiction is an efficient learner who has lost their liking for it, but wants it all the time. And that's the end stage of addiction. So this is from Kent Berridge. You see this is a review article in Trends in Neurosciences. And that led to this notion that he called incentive salience. And his mentor, T.E. Robinson, came up with this phrase that's actually in the paper that I love. This explains why life's intense pleasures are less frequent and sustained than intense desires. And all of us can relate to that, right? That the desires remain sometimes, and sometimes the pleasure isn't so great. Okay, so what does this incentive salience teach us about addiction? Well, it teaches us one thing that, in terms of your practice, is using the thought experiment with the patient of, don't you see how you will feel better if you stop using? It may seem helpful to you if you don't have a substance use disorder, you're not in recovery, but doesn't compute on an emotional level for most individuals early in recovery. They'll say, yeah, maybe, right? So you're trying to get them to do something that the motivational circuit is all swacked. It's not working right. So finding motivation, you have to do complex dances with people to find the motivation for remission, and that makes it hard to treat. Some of my patients have really benefited from learning how to parse out this wanting and liking. And it helps them stay away because they say, yeah, I get drunk, I have a headache the next day, I feel terrible. And I said, well, guess what? It's only going to get worse. You're only going to like it less and less over time. Most individuals are relieved to learn that their brain has been highly skilled at substance procurement. I always tell this story when I give this lecture as well. I had a patient that traveled across the United States for his work, and he was in fairly early remission. I think he was maybe 4 or 5 months in remission from a substance use disorder. And he flew out to Seattle on business, and he called me from the Seattle airport, from the Seattle hotel. And I said, are you okay? And he said, yeah, I'm doing fine. But I need to tell you something weird happened to me. He said, I got in the cab from SeaTac, and I was riding this was back when we had cabs. Do you remember those things, right? You got in the cab, and I got in the cab, and on the way there, I had this really weird feeling. I looked out the window, and I said to myself, I could buy drugs there. And he said it was just some neighborhood. And I said, well, give me an idea where it was. He wound up figuring out where it was on a map, sent me the address. I called one of my friends who's an addiction psychiatrist in Seattle, and I said, hey, tell me what this neighborhood is like in Seattle. He said, drug den, easy drug. So the ability to perceive on a subliminal level about where that is, and that can, for the alcoholic, if they walk in your house, they know where the alcohol is. They say, I think it's in that refrigerator. For the person who's trying to smoke a cigarette, trying to stop smoking cigarettes, they can sense where that is, right? And those that learned behavior becomes so powerful that you learn it just like you learn how to be self-preserving in terms of food. So, and then the last piece that's important is normalizing drug and alcohol hunger reduces negative self-concept. Teaching patients, when I don't on this level, but I teach my patients a little bit about this whole thing, that your brain's really good at finding drugs. Even if you want to stop, it's going to tell you it wants to find drugs or alcohol. And even though you don't like it, your brain is still convinced you should use. And they go, oh, God, yeah, that's what's going on in my head. How did you know that? Well, the brain science teaches us. Okay. I started at what time?
3 o'clock.
Sorry, 3 o'clock. Wow. So I'm only 15 minutes in. Oh, boy, you guys have, speaking of being tortured. We'll see, tell me when I run out of time. Would you do that? Because I could go on all day. This is actually a part of a training that I do in another context, and the lecture's an hour and a half long, but I'm not going to bore you that long, I promise. Okay, so we're going to move on to the next tranche of data about addiction, okay? That first is there are 2 different cycles. Having an addiction disorder is not a problem with substance use. It's a problem of being caught in a vicious cycle. And most people don't recognize all the parts of that. So this is a cycle, one cycle which is defined by the drug physiology. Some drugs have a half-life and wear out at a certain time, so it's all that drives this cycle. So if it's alcohol, if you have an alcohol use disorder, the drugs start coming out of the body, you start feeling withdrawal. That withdrawal drives drinking again, right? Everyone in this room knows that cycle. So the cycle has 4 phases: the use of the substance, and then the intoxication, and then a withdrawal phase. And depending on that substance, withdrawal can begin hours or days later. But that withdrawal drives continued use. So that cycle is probably everyone in this room knows that. If someone has an opioid use disorder, you figure out what the half-life is of opioids, you figure out how long the cycle's going to last. They're going to be in withdrawal 4 or 5 hours later, unless they take a very large dose, and it's going to be dose dependent. A larger dose means it's going to delay the withdrawal. Then they're going to have withdrawal, which is going to drive further use. So that's what we call the quick cycle. There's also a second cycle that people are involved in. This is the work of an amazing researcher, George Koob, and he talks about this, the brain physiology, not the substance that's used, drives this type of cycle. And with this cycle, you have a binge of alcohol use, and then you have this period where the alcohol use is stopped. Maybe you're not drinking for a couple of days because you have to go to your daughter's wedding and you don't want to mess that up. And you develop this thing that he has called hyperkatifia, which is driven by different parts of who you are. One is genetics, one is epigenetics, one is the reward deficit, so that you have this lack of rewards, and other things too, such as childhood trauma and psychiatric comorbidity. All those things drive how dysphoric and disturbed people are in periods of not using substances. That then produces, at times, if that goes on, and by the way, there's also this period where the urgency to use substances is low. But at some point, it begins to shift around towards preoccupation and anticipation, where they say, I said I'd go to my daughter's wedding and not drink. I'm just really stressed out about all this. You know, she's always been mad at me about having my alcohol problem. I said I wasn't going to drink, but geez. All that is that hyperkatifia. And then you begin to have problems with executive functioning. That fore part of the brain in that particular individual, the worst time he can drink is going to his daughter's wedding, right? So he's going to wind up drinking, making a fool of himself, pissing off his daughter more, and yet paradoxically, that happens so often in people with substance use disorder. They choose the exact wrong time to relapse or to affect others. And that's why everyone's so angry at them. So this is an actual case. That patient that I'm describing went to his daughter's wedding, stayed pretty well through the wedding, went to the reception, and guess what happened? Right? People were laughing, having a glass of champagne. He said, one glass of champagne won't hurt. His executive functioning, the part of the brain that says no, goes offline. He drinks again, gets drunk. One of his other children have to take him away from the reception. He feels terrible. He comes back in the office. He says, I am hopeless. Well, if you say to people, if you help people understand that there is this cycle that occurs in your brain, your problem is not that you drink. It's that you're caught in this cycle of drinking, reacting to the effects of the drinking, executive function goes offline, drinking, and that cycle goes over and over and over. And if in patients that have substance use disorders, they do it with incredible finesse. He got drunk at the worst possible time. He was hoping to have his daughter be proud of him, and he blew it in the biggest way possible. And what happens with us as people that care for them is to say, what? Why are you doing that? Well, his brain has literally learned that process. Okay? So, what does all this mean about treatment and recovery? Well, patients should be taught about these cycles and normalizing them, saying, look, you're going to go through a period of where you're going to feel okay after, early in recovery, but it's going to come back. So we have to prepare you for this. And your executive functioning, which we'll talk about in a minute, is going to go offline. And so you're going to have things in your environment which protect you. Learning these stages will help them pull themselves out of that substance use cycle. Okay, how much time do I have left? Someone tell me. 15 minutes. Okay, I'm going to bore you with one more set of goodies that happens in the brain, okay? Is that all right? You with me? Okay, good. So earlier, if you remember, I talked about the fact that this dopamine reward complex projects anteriorly here to the amygdala. To the prefrontal cortex. But it projects all the way up in the prefrontal cortex and actually in the motor cortex and the striatum. So this dopamine circuitry, which appears to trigger a lot in people with substance use disorders, has a lot to do with the frontal cortex. So we're going to talk about the frontal cortex and how it's affected. And to do that, we're going to take a look at a federal government slide. Do you know why you can tell it's a federal government slide? Because this is a picture of a plastic brain that was laid down on a table and someone just got a camera and took a picture of it. A drug company slide has this is a drug company slide. This is a federal government slide. But it's helpful. If you remember, we've already talked about this reward and salient circuit here. It's called VP here. That means ventral pallidum. That's another name for the for that area, and the nucleus accumbens. We've talked about that. And next, we're going to talk about these two areas in the frontal cortex. And the first one we're going to talk about is inhibitory control. Why is inhibitory control offline and what we can do about it? There are two areas that get derailed by inhibitory circuits. The first is the dorsolateral cortex. It's an area in blue. Oops. Oh, and it looks like the other area you can't see. The other area is actually the orbital frontal cortex, which for some reason is showing up today, which is way down here. Orbital frontal cortex means if you stuck a finger in your eye and you put your finger up, you tap the orbital frontal cortex. So these areas of the brain are involved in inhibitory decisions, immediate versus delayed responses, and weighing the various value of goal-related behaviors. Really important in Homo sapiens, and that's why the frontal cortex has grown so much, is some of these important functions. Once you develop addiction, because of this same dopamine circuitry, it decreases sensitivity to non-drug reinforcers and decreased ability to inhibit maladaptive or disadvantageous behaviors. And you can sometimes even do psychological testing and pick this up on psychological testing in people early in remission from the illness. It's the work of Rita Gold et al. So what does that mean? Well, it means that in most cases, external constraints have to be used to interrupt destructive use. You have to have some way of stopping people to use. Wagging your finger is not an inhibitory control. It's just wagging your finger, right? What does help is providing, so probably the best description of that is if someone's going to stop smoking, for instance, you tell them to get everything that reminded them of cigarettes out of the house. Get rid of the ashtrays. Wash all of your clothes. One of my patients said, I couldn't stop smoking until I bought a new car because it didn't smell like smoke. She was a very bad nicotine addict and literally had to sell her car in order to do it. But we figured that out after a while because she would relapse every time she got in her car. And I said, well, you think it's the car that's doing this to you? She said, I think it's the car. Okay, let's just get rid of the car. So external constraints have to be used. Now, external constraints can be in various forms. People going into a treatment setting where they have enough control around them, a biological control, such as using antabuse for a period of time with an alcohol use disorder, using drugs like buprenorphine or naltrexone for opioid use disorder. In my group, in taking care of physicians with substance use disorder, we use drug screens. Because the threat of a positive drug screen in a physician who understands that is sometimes enough to have them say, I just don't want to have a positive drug screen. I just don't, you know. And that, if they're far enough along, that in and of itself, there have to be external inhibitory controls. You can't expect someone in the midst of a severe addiction to just say, okay, I'll get willpower. If they say that to you, you should say, it's not going to be enough. Let's figure out what we can do in your environment to make it change. So the other case is, because I've treated a lot of physicians in my life, I had one physician many years ago who collected wine, and he was an alcoholic. And he said, I've got expensive bottles of wine. You can't tell me to get rid of that. And I said, yes, I can. I said, if you want to get better, sell it. Buy a Ferrari or something with all the money you make off all the wines you sold. And what did he do? He didn't sell the wines. What happened then? He relapsed. He came back to see us again. I said, are you willing to sell the wines this time? He said, okay. And he didn't buy a Ferrari. He just didn't have that many wines, I guess. So that means external constraints have to be used in almost every case. You can't expect individuals in early recovery to execute conscious, effective, continual decisions not to use. It also means that environmental cues and certain emotional states and stress-induced craving have to be minimized at first. One of my best examples of that is I had a guy who drove to work every day, and he was in remission, and one day he came to see me in my office. He was about 2 months in to his remission from alcohol use disorder, and he said, I figured something out. When I have a tough day at work, I drive home down Peachtree, and I go down, he told me they're out. I said, okay. He said, every time I do that, I drive past my favorite watering hole, my favorite bar. And I said, well, I don't mean to be stupid here, but I have a simple solution to that. He said, well, what's that? Thinking I would be wise. And I said, drive home a different way. He said, oh, I never thought of that. And early on, decreasing the stimuli that produce relapse is important. That means that a lot of intensive, difficult psychotherapy on someone who's not in a controlled environment, controlled environment's totally different, not a controlled environment, may not be great at first. Maybe just figuring out how to behaviorally survive until the brain normalizes. And exposure to indirect substance triggers have to be delayed until your inhibitory controls come back online. What happened with that guy, by the way, the driving home guy, is after a period of time, we actually, believe it or not, this is what we talked about in therapy. You're going to think I'm a terrible psychotherapist. What, are you ready to drive home in a different way? Well, he said, well, no, not yet. Okay, well, what I want you to do is drive 5 blocks away and then turn around and go around. Next week he came back. So I did that. Okay, this time 4 blocks away, turn around. And over time he went to expose, and it was a repeat exposure to the problem with him having small incremental increases in success until he drove by and went like that to the bar, right? And he's in remission today, doing well. Okay. I think I'm going to stop there because I've got a whole lot of lots of things. Let's just see if there are any questions or comments, and especially comments about what you found helpful or you felt was not helpful. That's always helpful for me to know. Yeah.
Talk about triggers and the environment. Okay, what if you have a spousal arrangement? Spouse is a heavy cigarette smoker, or your spouse is alcoholic, and you're trying to help the husband or the wife.
You've done it?
How do you? Yeah.
Why don't you start over? Because I don't think some people could hear you on the record.
All right, in a marriage, a spouse who also has a substance abuse. No one lives in a vacuum. So how can you treat family, close family members, and to help them get clean?
Yeah. So let's do the cigarette one.
Yeah.
I have never had success having someone stopping smoking if their spouse smokes. You did. Okay, well, incredible. The exception that proves the rule. Was it easy?
No.
Okay.
He said, you want some?
Oh, you're kidding. Yeah. So that's another thing people do. Come on, be miserable with me. Have a cigarette, right? Yeah, okay. So, and paradoxically, just watching how you said that, I would bet that you're someone that when he said that to you, you went, yeah, that's it. You didn't see that over here. She had the head shaking. You ain't going to make me smoke. right? And that might have been what made you get through it. But in general, as a general rule of thumb, if someone, one half of a spouse, of a spousal relationship comes in and says, I want to stop smoking, the first thing I would do is I would say, bring your husband or wife in next time. Let's figure this out. Let's talk it through. See what we can do. If it's possible, it is possible to have that person do something like smoke outdoors or do that sort of thing. But in general, the rule of thumb is it's almost not worth the expected failure that you're going to have to try that. So what I would probably do in a situation is, no, he won't. What he'll do is he'll go out in the backyard every time he's smoking. Will he really do that? Yeah, he'll really do that. You're convinced of that. And if that doesn't happen, then you use that as a format to say, let's work on both of you getting in remission. And then you do the things, you get rid of every ashtray in the house. You wash all of the clothes, the bed sheets, the linens. You have the car detailed if you can afford it, or you vacuum it out yourself. You find out where the favorite smoking locations were, and you don't go there for a while, you know? If it's the back porch, that back porch is off limits for a period of time. So you think through the specifics of that. It's not rocket science. It's actually kind of fun. But what I do with couples when they do that is I say, it's just not going to work. And I start at that place. And they say, oh, come on, doc. I mean, you're a wimp. Why can't you figure this out? Blah, blah, blah. I thought you were supposed to be pretty good. You know, all the stuff that people say, right? And you just wind up kind of working with them until they get some willingness. For people that have an alcohol use disorder, it's actually a little more successful if the spouse drinks, especially if that spouse is drinking in a way that causes a negative reaction. You know, you have a husband whose wife drinks and kind of is slurring her words and is unpleasant, you know. You can say, come in and tell me about what it's like to be with your wife. And then they say, oh, you know, I used to think she was funny, and now it's kind of like, yeah. But with that group, using support networks is helpful. If you can get someone like that in the alcohol case to go to Alcoholics Anonymous, then they will teach that individual how to tolerate the spouse that smokes. And then they'll start going to Al-Anon actually as well. Who smokes, who drinks. I'm sorry, I may have misspoke there. So there are lots of things you have to do to kind of work this through. It's not a quick fix, but on sequential seeing a patient over time, you know how you get to know a lot about them in little snippets, even if you're a general practitioner. I'm making that assumption. You get to know a little bit about that family. You can wind up finding ways of directing it. And then finally you say, what are you willing to do if this doesn't work? I've had people that have gone to inpatient treatment to stop smoking, for instance. And unfortunately, that's usually people that are starting to get emphysema. But you say, let's try this. If this doesn't work, we will keep on moving up the ladder until we get you some help. And that way you're saying to people, and you kind of frame it around, different people need different stuff. Some people need the whole Megillah. They need the whole thing. Some people can do that on their own. And but your compassionate response is what they're going to respond to, and your practicality. Okay, so that didn't work. Rather than saying, God, that didn't work, because then you're all out of stuff, you know. And you call, you know, an addiction medicine doc and say, can you help me with this? And they'll say, yeah, I'll see him or I'll do that sort of stuff. There are people today that do addiction medicine full time. I've been doing this for 40 years now. So I'm one of the old guard, and hair's not quite gray yet. But there are lots of new people that are being trained in addiction work and can help you with those decisions as well. Great question. Yes.
Hi, very interesting lecture. I'm an ER physician over 20 years, and I'm seeing less alcohol abuse and more recreational cannabis abuse. My question is, a lot of, especially in college students, are doing a lot of cannabis for anxiety. And my question is, with medical or medicinal cannabis, are you seeing the same level of addiction as we're seeing with recreational cannabis use?
Yeah. Medicinal cannabis is recreational cannabis too. I mean, it's the same. And I assume you're not talking about the low THC oil stuff. You're talking about pot or cannabis.
Right, so
Yeah.
we're seeing a lot of addiction with pot use, marijuana use.
Yeah. So, well, I have to expose my prejudice here. This is the same old, this is industry-driven addiction, just like alcohol is, just like tobacco is, and we're going to be in the same hole that we were with alcohol. Not the exact same set. We're going to have more people that have anxiety induced by pot. We're going to have the hyperemesis syndrome. I'm sure you see a lot of that in the ER. You'll see people, especially young adults, that become psychotic on pot. Marijuana induces psychosis in susceptible individuals. And you're taking people that could probably have snuck through adolescence without psychosis, and you're giving, and for people that are my age, and when I was young, pot was 4% THC, and now it's 80% THC, and they're taking a different drug than, it looks like a lot of us are a little older in here, so I can say this. It's not your mother's pot. It's this is a different thing, and the industry, the marijuana industry, by the way, just like any other industry, they're always trying to, make it more potent, right? Because you sell more of it that way. So yeah, we're going to have more psychosis, more hyperemesis, more anxiety disorders, and more addiction with marijuana. It produces addiction just like the other substances do. There are people who say, "Oh, it helped me stop drinking as much." Well, okay, maybe. There might be a few examples of that, but for every one of those, there's a bunch of other people developing addiction disorder. So it's not safe. Now, just like alcohol, though, almost no one becomes a casual cocaine or heroin user. There are a few, 0.001% maybe, of people that can do that. But marijuana, alcohol are substances that people can be casual users from and not become addicted to. But we're going to see the same thing. 10% of the American population during the course of their lives will have an alcohol use disorder. This is not a rare condition. So if you're not seeing it as 10% of your patients are hiding it from you. Yeah.
I just thought maybe because the medicinal, they limit how much THC you can have in it. It's usually, 5% or less, that you may get less addiction potential versus the recreational, because you don't know what they're putting in it, the percentage of THC.
Well, so I don't know enough about the medicinal THC vendors, but they're selling a product. And if the FDA came in and said it will contain 10% THC, okay, I believe it. If the company is saying we regulate the amount of THC in our product, I'd go, yeah, the pig's eye, right? I mean, geez, I'm not that naive, right? So yeah, and there are different people's sensitivities to THC are different.
That's true.
I've had people that have had a psychotic break on limited amounts of THC, 5 uses of not very high THC marijuana, and had a psychotic episode. So it is possible. Yeah.
There's a question over here.
Oh, okay.
Your turn.
Okay, my question is, what happens, a recent college graduate comes in and tells me, 6 of my uncles are alcoholics. What can I do to prevent me being an alcoholic?
Wow, what a great kid that is. First of all, you say, congratulations for doing that. Addiction is a genetic illness. The single biggest driver, the single biggest predictor about whether you're going to have an alcohol or drug problem are your genetics. And that data is very clear. The quote that I give, that is sometimes misinterpreted, so I need to be clear about how I say it, is 50% of the driver for addiction. It doesn't say 50% of the people. 50%, if you were to take a look at the drivers towards developing addiction, half of that comes from your genes. So when I teach the medical students, I say, if you can figure out how to ask non-invasive, non-shaming questions about family history of substance use disorders, you can have a good conversation with your patients when they're younger. So the simplest thing to do with your guy who's coming in is say, congratulations. Your worrying about it is probably the healthiest thing you can do. Just like if half of his family members died at age 30 of coronary artery disease, you'd say, well, let's be more aggressive about that. Now, do we have medicines that prevent addiction? No, unfortunately. But you can look at the other things which contribute to addiction. Is there any trauma in that person's history? Do they have problems with self-esteem? Do they have problems with anxiety? Do they have a problem, any of those types of psychiatric conditions which tend to nudge people in the direction of developing addiction? And you treat them aggressively. And you say, with that many people in your family, if you drink a certain amount, it's pretty clear that you may wind up developing the illness. So my first recommendation is maybe you can go through life without using substances. A lot of people do it. The people that do it don't kind of wear a sign that says, I'm not doing it, so you don't know who they are. But a lot of people don't use substances. So I would, congratulations is the first thing. My family, I'll tell you a story, my family is riddled with addiction. And when my kids were 10 and 8, we sat them down and said, let me be clear with you about this. Both your mom's and your dad's family have addiction all the way through it. If you drink alcohol, they were 8 and 10, and they both said, oh, Daddy, we would never do that. Or if you smoke pot, oh, I've heard of the high school students doing that. I wouldn't do that, right? But, they're 8 and 10, right? And we had that conversation, and we had smaller conversations after that. And later, our kids are grown now, and they both say to me, you ruined it, okay? You ruined it. And I said, good.
So, do those people do other addictions like obesity as opposed to drugs per se? Do they have that kind of personality?
Yeah, okay, yeah. So the other question was, do other addictions, obesity, you were saying, well, gambling disorder, sexual compulsivity, all those co-migrate with substance use disorders. It's a little more unclear about obesity, but if the GLP-1 data is telling us, those drugs might be really helpful in treating addiction as well. So there's some sort of thing that's happening there. And I think the data about obesity is not as clear, but there is binge eating disorder. Tends to occur in people that go on to develop alcoholism. If you have a young person who has bulimia nervosa, they tend to become alcoholic when they turn 20. That's one of the most common paths. Okay.
Yeah.
Thank you, Dr. Earley.
Oh.
Wonderful presentation.
Thank you.
Go ahead, one question. I have one. Okay. Yeah, I had it. Continuing your excellent talk, and all the talks have been excellent today, the question is, have you seen any utility in ketamine as an adjunct to allow this? Because in the group we're working with, we're looking at ketamine as something to aid in this whole thing because of the brain chemistry.
Well, first of all, ketamine is a drug that in a small quantity of people is highly abusable. So if you're going to use ketamine in the treatment of alcohol or drug dependence, you really need to know what the hell you're doing, or you might be causing more problems than you're fixing. However, a large percentage of people that have alcohol or other substance use disorders also have a mood disorder. So there may be a case that can be made for treatment refractory depression that has failed SSRIs, failed some other more conventional interventions, to use ketamine if there is a substance use disorder. But beware, because this surge we're having in ketamine, like the pot issue, is because people self-select for it a lot.
Sure.
We've created just another crazy problem. And the same thing, by the way, goes for hallucinogens. The hallucinogen research may be helpful, but it's going to have some side effects. Trust me on this one. It's going to, 10 years from now, we're going to say, what were we thinking, right? And to some degree with ketamine, although ketamine clearly has, I've had some really remarkable remissions in depression with ketamine. And if it's done carefully with the right people and the warnings are there, I would not use it to treat addiction.
Yeah.
Because people especially if people are using fairly intense drugs, because they're going to say, oh yeah, man, I used to like some cocaine, but this ketamine's pretty cool too. And then they're going to buy it on the street. So careful, judicious use is indicated there. And I think there's going to be a collateral effect of all of this re-expansion. I grew up in the psychedelic times, and we're back there again. It's kind of interesting. The difference is that there's some science involved in it. People are being a little more careful in how we're applying it. But as we've always found, if it shows up in the medical field, it often dribbles out into the community as well. Oh, yeah, ketamine's not a problem. My friend was using it, so I'm going to use it recreationally. Thank you.
If you found this content valuable to you, please consider joining SMA by visiting sma.org/membership or making a tax-deductible donation. Visit sma.org/give to support our mission. Thank you.